Hi, my name is Dr. Deodhar, and on behalf of my co-authors, I'm pleased to share with you the highlights of our publication entitled Efficacy and Safety of Tofacitinib in Ankylosing Spondylitis by Baseline C-Reactive Protein Level Post-Hoc Analysis of Phase 2 and Phase 3 clinical trials. Ankylosing spondylitis is a chronic inflammatory disease affecting the spine and sacroiliac joints on the axial spondyloarthritis disease spectrum. Elevated CRP is a marker of inflammation in ankylosing spondylitis, and previous studies have shown that elevated CRP levels can predict clinical response and structural radiographic progression in patients with AS treated with tumor necrosis factor inhibitors and interleukin-17 inhibitors. Elevated CRP level versus normal CRP level at baseline was associated with achieving a better clinical response to treatment with etanercept, infliximab, or adalimumab. Elevated CRP level at baseline or at weeks 14 or 24 was linked with the risk of subsequent structural radiographic progression in patients with AS receiving golimumab. Given these findings, as clinicians lack tools to help determine which patients may respond best to certain treatments, measuring CRP levels might be considered to guide their decision-making. Tofacitinib is an oral JAK inhibitor, Janus kinase inhibitor, for the treatment of ankylosing spondylitis. The relationship between CRP level at baseline and clinical response and safety in patients with AS has to date not been studied in detail for JAK inhibitors. The objective of this study was to assess the impact of baseline CRP level on efficacy, patient-reported outcomes, and safety of tofacitinib in AS. In brief, this post-hoc analysis used pooled data from phase 2, which is a 16-week study, and phase 3, which is a 48 weeks study. These were randomized controlled trials in patients with active AS aged 18 years or older who fulfilled the modified New York criteria for ankylosing spondylitis. Patients receiving one or more doses of tofacitinib, 2 mg, 5 mg, or 10 mg twice daily, or placebo, were stratified by baseline CRP level of less than 5 mg per liter, which is normal, or more than or equal to 5 mg per liter, which is elevated. Efficacy endpoints assessed up to week 12 using data from both RCTs and week 16 using data from phase 3 RCT only included response rates for ASAS-20, ASAS-40, ASDAS-CRP low disease activity, BASDAI 50, and least square, which is LS, mean change from baseline in ASDAS-CRP and BASDAI. Endpoints assessed up to week 48 for phase 3 randomized controlled trial only included response rates of ASAS-20, ASAS-40, BASDAI 50, ASDAS-CRP LDA, and LS mean change in ASDAS-CRP and BASDAI. The patient-reported outcomes assessed up to week 12, this is data from both RCTs, and week 16, which is phase 3 RCT only, included LS mean change from baseline in nocturnal spine pain, FACIT-F total score, AS quality of life, SF36 PCS, which is physical component score, BAS-ME and BAS-FE. This is Bath Ankylosing Spondylitis Metrology Index and Bath Ankylosing Spondylitis Functional Index. Safety outcomes include treatment emergent adverse events, TEAEs, serious adverse events, which is SAEs, and discontinuation due to adverse events, infections including serious infections, serious and non-serious herpes zoster, adjudicated opportunistic infections, and death. This is all-cause mortality up to week 16 and week 48. Data from 372 patients were analyzed, which included 185 patients treated with TOFA and 187 patients treated with placebo. In total, 69.6% of patients had a baseline CRP level of more than 5 milligram per liter. In the baseline CRP level of more than 5 milligram per liter group, in both tofacitinib and placebo group, more patients were male and had a BMI of more than 30 compared with a CRP level of less than 5 milligram per liter group. A higher proportion of patients receiving placebo with baseline CRP of less than 5 milligram compared to those with more than 5 milligram, and also compared with patients receiving tofacitinib 5 milligram BID with baseline CRP of less than 5 milligram, used non-steroidal anti-inflammatory drugs and sulfasalazine. Firstly, we examined the efficacy endpoints by baseline CRP levels. At week 12, regardless of baseline CRP level, response rates were higher for tofacitinib versus placebo across all efficacy endpoints, including ASAS-40 and ASAS-CRP, low disease activity. Next, we looked at the change from baseline in the ASDAS-CRP and BASDAI. At week 12, regardless of baseline CRP level, the LS mean change from baseline in ASDAS-CRP and BASDAI was greater for tofacitinib versus placebo, and the treatment effect, and by that I mean placebo-adjusted response, was greater in patients with baseline CRP of more than 5 mg per liter compared to those with less than 5 mg per liter. When placebo-treated patients in the phase 3 randomized controlled trial switched to receiving tofa 5 mg BID at week 16, the LS mean change from baseline for the two endpoints increased in magnitude from week 16 to week 24 and remained stable up to week 48. Moving on to PROs, this is patient-reported outcomes at week 12. Regardless of baseline CRP level, the LS mean change from baseline across the PROs, which includes nocturnal spine pain, FACIT-F total score, this is for fatigue, and BAS-Phi, this is for function. These scores were greater for tofacitinib versus placebo, and the treatment effect, which is placebo-adjusted response, was generally numerically greater in the baseline CRP of more than 5 mg per liter versus those with less than 5 mg per liter subgroups. These trends continued to week 16. And finally, moving on to safety results, patients with baseline CRP of less than 5 mg per liter receiving tofacitinib had numerically higher incidence rates for TEAEs, all infection, serious infections, and SAEs compared with placebo, whereas in patients with baseline CRP of more than 5 mg per liter, the incidence rates for these were similar for tofacitinib versus placebo. Up to week 48, tofacitinib treated patients had numerically higher incidence rates for TEAEs, all infections, and SAEs in the baseline CRP less than 5 mg per liter versus more than 5 mg per liter subgroup. There were very few cases of discontinuation due to AEs, herpes zoster, and serious infections. There were no deaths and adjudicated opportunistic infections. The most common TEAEs by system organ class were infections and infestations, gastrointestinal disorders, musculoskeletal and connective tissue disorders, and investigations. Limitations of our analysis included that the analysis was post hoc, follow-up duration was short, and there were differences in baseline patient and disease characteristics. The sample size in some groups was small, particularly in the safety cohorts, which made it difficult to observe any consistent trends in the safety outcomes. The relatively short treatment exposure and small sample size limited our ability to assess long latency or less frequent adverse events. In conclusion, regardless of baseline CRP level, tofacitinib was more efficacious versus placebo at week 12. The placebo-adjusted efficacy and the patient-reported responses were generally numerically higher in patients with CRP more than 5 mg per liter versus less than 5 mg per liter. The higher non-steroidals and sulfasalazine exposure may have improved efficacy responses in the baseline CRP of less than 5 mg per liter placebo group and ultimately affected the tofacitinib treatment effect. Safety was consistent with previous studies of tofacitinib in AS, with numerically higher TEAEs and all infection incidence rates for tofacitinib versus placebo in patients with baseline CRP of less than 5 mg per liter. Thank you for listening.